Disclosure-wise, I have no financial disclosures, unfortunately. If you'd like to give me some money as a tip afterwards, I will definitely take it, with the economy being as it is recently. During this part of the talk, I always think it's kind of a funny portion of the talk, so I feel like I have to share something that is embarrassing about myself. And so I have to say that I actually did watch a single episode of American Idol this year with my wife. I was forced into it, but it is something that I had to disclose. I promise that I'll try not to do too much in regards to humor, but this does wake me up when I give these talks. So we're going to talk about ankle ultrasound. I'm just curious, how many people actually perform ankle ultrasound in their services? That's good, quite a number of people. As you all know, this is more of a focus exam. We typically have patients who have pain referred to a particular region, and so we like to compartmentalize this. We typically look at certain structures, but we compartmentalize it into an anterior, a lateral, a posterior, and a medial compartment. We'll go through all of the structures in a systematic way. Typically, we'll focus on one area and look at all those structures, and we have our technologists look at certain structures in the same way so that when we look at the images, we'll be able to go through them quickly. If you do set this up in your practice, it is nice to have them in the same sequences. We'll talk a little bit about our protocol as well as spend some time with the normal anatomy about the ankle. I won't spend too much time on technique because I know several of the other speakers have talked about how to visualize the tendons and nerves. Well, obviously you want to keep your transducer 90 degrees to these structures to prevent anisotropy so that we don't overcall tendinopathy or tendinosis, as well as not to overcall tears. Throughout the talk, there will be some common pathology referred to some of the structures we're looking at, and also potentially some treatments, which obviously ultrasound is very amenable to doing procedures, and it's the one thing that I think is a huge advantage over other cross-sectional techniques, is that we're able to actually perform procedures at the time of diagnosis. For the ankle, most of these structures we'll look at are fairly superficial, so you want to use a high frequency transducer. Today we'll probably be using the linear 17.5. You can use a compact linear, otherwise known as the hockey stick as well, particularly if there are certain structures you want to get some high resolution on, maybe some of the smaller nerves around the ankle. So again, we're going to compartmentalize this. Here's an MRI just above the level of the tibial talar joint. Anteriorly, we're going to be looking predominantly at the extensor tendons, the anterior tibial artery, as well as the deep peroneal nerve, which is the largest terminal branch of the peroneal nerve. It does supply the extensor digitorum brevis and some sensation to the dorsal aspect of the ankle. Immediately, we'll key in on the three flexor tendons, as well as the major coronal stabilizer, medially the deltoid ligament, as well as the tibial nerve. Posteriorly, our major focus will be the Achilles tendon, and laterally, we'll focus in on the lateral collateral ligament complex, which is the major coronal stabilizer on the lateral aspect of the ankle, as well as evaluate the peroneal tendons. So, as with anything in ultrasound, positioning is key not only for comfort of the patient, but also comfort of the patient performing the examination. For the anterior ankle, typically we place the patient supine. We have the knee flexed approximately 45 degrees with the foot flat on the table, as you can see in the diagram here. I like to put my transducer to show the cross-sectional anatomy in the transverse plane of the tendon starting out, and then migrate both caudally and cranially to evaluate the tendons along their full extent. We then will subsequently turn the transducer along the long axis of the extensor tendons. Most people like to use mnemonics to remember the anatomy. There is one for both the anterior and medial ankles. For this one, most people like Tom hates Dick. I showed this to my 5-year-old. He thought hate was a little bit negative, so I have now going to switch it to Tom hugs Dick because he felt that that was a more appropriate thing to do. So Tom is for tibialis anterior. Hug is for extensor hallucis longus, and this is going from medial to lateral, and Dick is for the extensor digitorum longus. Here we can see on the magnetic resonance imaging examination the tibia. This is just above the tibial talar joint, and we can see the three tendons and going from medial to lateral, tibialis anterior, extensor hallucis longus, extensor digitorum longus as well. Here we can see the bony anatomy as well as the ligamentous anatomy, with the tibialis anterior coming down, coursing along the dorsum of the foot along the medial aspect, and attaches to the medial cuneiform and along the undersurface of the base of the first metatarsal. Next up is the extensor hallucis longus, coursing along the dorsum of the foot and attaching to the distal phalanx of the great toe, and the extensor digitorum longus above the tibial talar joint usually looks like a single tendon with a tendon sheath, and then subsequently, as you image more distally, will turn into 4 separate tendons extending to the 2nd through 5th digits with their own tendon sheaths. You can see here there are 2 hypoechoic structures. We'll look a little bit more of this in detail. This happens to be the deep perineal nerve, and underneath that is going to be the anterior tibial artery. If we look at those structures above the level of the tibial talar joint, here is the anterior tibial artery, and here's the nerve. You can see that the deep perineal nerve is actually on the medial aspect of the artery. As it descends, it will cross over the artery, so as we go a little bit lower and near the level of the actual joint, you can see that now it is sort of centrally located in respect to the tibial artery, and as we go more distally, you can see it finally lies along the lateral aspect. Important to identify this structure. People with anterior impingement can actually get neuromas and fibrosis surrounding these nerves and pain to this region. I have often injected this particular nerve in several of our football players because of anterior impingement with surrounding fibrosis. Well, as I said, we like to look at the tendons also in their long axis. So here we're looking at the tibialis anterior. If you ever feel like you're getting lost into the anterior tendons, you can just have the patient either lift up their toes or dorsiflex the ankle, and they usually are commonly seen just on physical exam, and you can just place your probe directly on them. Again, it's going to have the typical fibular appearance, and we can see this extends down all the way down to the medial cuneiform. Again, you can see it extends all the way, traversing the ankle joint, making its way to the medial cuneiform, with a small portion also going to the base of the first metatarsal. This happens to be the most common of all the extensor tendons to actually be injured. It is rare to see injury or tendinosis of the other tendons. Here we can see a patient with a long field of view ultrasound with marked enlargement of the proximal aspect of the tibialis anterior. And you can see in short axis, the tendon is markedly enlarged. Although it can be slightly larger than the other extensor tendons, it shouldn't be 4 times larger than as it is seen in this particular case. Also, there was a little bit of fluid within the tendon sheath and slight thickening of that tendon sheath consistent with tenosynovitis. As I alluded to earlier, one of the big advantages of ultrasound is that we have the ability not only to diagnose pathology in several areas of the musculoskeletal system, but we're also able to treat them. This is another patient who came in. The patient had a normal looking tibialis anterior. You have to trust me that we looked at the entire portion. However, they had marked tenosynovitis. There was extension and distension of the tendon sheath. You can see thickening of the tendon sheath as well as the synechiae and adhesions. And with color Doppler, you can see areas of hypervascularity. I typically like to place my needle when I'm doing injections into the tendon sheath via a transverse approach. I find that the tendon sheath can often be thickened and difficult to penetrate when we do it along the long axis, so I prefer the short axis. Here you can see our needle penetrating in. I usually place a small amount of anesthetic to confirm that I'm actually within the tendon sheath, and note that there is circumferential fluid surrounding, with this anechoic fluid surrounding the tendon, and then subsequently place our mixture of anesthetic and steroid within the tendon sheath to treat these patients with extensive tenosynovitis. Anteriorly, we also look at the tibial talar joint. It's an interesting hinge joint. You can plantar flex about 50 degrees and dorsiflex about 30 degrees. You do have a little bit of tilt that's allowed because the talus is actually somewhat triangular in shape, with the posterior aspect of your talus being more narrow than the anterior aspect, so you can have a little bit of tilt when your foot is in plantar flexion. Here we can see this hypoechoic structure overlying the talar dome. This is the articular cartilage. With ultrasound, you can see approximately 60 to 70% of the cartilage, so it's important for you to go side to side. This is the sagittal plane here that we're looking at, so you want to move your transducer medial to lateral to evaluate the cartilage. You can't see all of the cartilage, but you potentially can see areas of chondrosis, and we have caught a couple of patients who had osteochondritis dissecans, which we actually saw on ultrasound. Where my little asterisk is, there is the anterior recess of the joint. Again, This is the tibia here, here's the talar dome, this is the talar neck, and here's the talar head, and this is the anterior recess. This is where I look to see if there is a small joint effusion. You usually see that best with the patient in plantar flexion, although it's important to evaluate the tibial talar joint in both dorsiflexion and plantar flexion. By moving the joint, sometimes you might actually identify a small loose body that will be mobile and flop right into the field of view. Also see small joint effusions potentially by doing those kinds of maneuvers. The other nice part of this particular area of the ankle is that in the ankle, the capsule is usually fairly tightly adherent to the bones, except anteriorly. Here, anteriorly, typically the capsule will attach to the tibia and course all the way down to the neck of the talus, giving ample space to course a needle into the tibial talar joint. This is sort of how my fellows do it, where they traverse the tendon. I recommend not doing that. Position your probes so that you can see between the tendons and make sure you don't hit the neurovascular bundle, and then extend it right into the joint space. You also want to look to make sure that there aren't large osteophytes off of the anterior aspect of the tibia or off of the talar dome. That would be a sign of impingement. Again, you can flex, dorsiflex and plantar flex the ankle to see if those osseous structures are abutting, and if the patient has signs of anterior impingement, typically have pain. Again, go back to that deep perineal nerve, make sure it doesn't have fibrosis around it. Often we'll give them an injection in that area. So let's move on to the lateral aspect of the ankle joint. Now we're going to position the patient in the decubitus position. Our main osseous landmark is going to be that fibula, the lateral malleolus. Once you feel the lateral malleolus, you can place your transducer transversely across it. And when looking at the tibiofibular ligament, you have to realize that the ligament actually has an oblate course with the more medial aspect somewhat superiorly located as it traverses from the fibula to the talus. And therefore, if you position your transducer in such manner, you will elongate the tibiofibular ligament. Here we can see the shadowing of the lateral malleolus. Here we find the tibia, and here are the ligaments of the tibiofibular ligament. Again, another advantage of ultrasound is that we can stress each of these tendons and ligaments. And for this particular area, if you have the patient dorsiflex, you can actually make the tendon slightly more taut. There should not be much diastasis between the lateral malleolus and tibia as seen here. This was a totally normal tibiofibular ligament. It can be injured in the setting of a high ankle sprain. It's important to make sure that there's not much diastasis between the bones or discontinuity of this ligament when imaging under ultrasound. This patient came in, they had a known deltoid ligament injury. They were very lax medially. Here on radiographs, this is the tibia and this is the talus. Here you can see widening of this medial clear space with a small avulsion fracture. This patient had a deltoid ligament tear with an avulsion. The clinicians were worried more so that they might have a high ankle sprain and injury to the anterior tibiofibular ligament. On ultrasound, you can see here's the fibula. This is a short axis view. Here's the tibia, and we saw fluid interspersed and going through this area of discontinuity of the tibiofibular ligament. Often you can see hemorrhage in there. It can be very hypoechoic. Often you can see fluid going in there. Again, dynamic imaging can help if you're questioning between a partial tear and a full thickness tear. Here's the corresponding MRI on the same patient. Here's the fibula. Here's the distal tibia. This small little dark area is the only remnant of that tendon, and then you can see the area of discontinuity, which correlated with what we saw on the ultrasound and in keeping with a high ankle sprain. Well, once you are on the lateral side, you keep your transducer right on that lateral malleolus. And in order to look at the talofibular ligament, you will now get the medial aspect of your transducer and aim it slightly inferiorly to go along the course of the anterior talofibular ligament as outlined here. It's easy to discern between these two ligaments given the differences in obliquity, given that the tibiofibular course superiorly and the talofibular courses inferiorly. It's easy to actually identify them as separate structures. This happens to be the weakest of the ligaments along the lateral collateral ligament complex and is the one that is most commonly injured. Here, in order to evaluate this and place stress on it, you will put the foot actually in plantar flexion inversion and often have to put the foot off to the side of the bed. You can then pull on the toes anteriorly. This is called an anterior drawer test, similar to what you would do in the knee. And while doing that, if you see diastasis of the lateral malleolus and talus, you know that it's going to be a full thickness tear. You also will see gapping of the ligament. Here's an example of what it will normally look like. Again, you can see the ligament, will become somewhat taut, but no discrepancy or increased diastasis between the lateral malleolus and talus, and definitely no evidence of discontinuity of that ligament. Here's an example. This is the normal contralateral side. This case was given to me by Dr. Kenneth Lee with a nice fibular pattern of the anterior talofibular ligament. Here, similar to what we saw with the prior case of the tibiofibular ligament being injured, we saw fluid coursing through the area of discontinuity, and on dynamic imaging, there was gapping of these two portions of the tendon. This is the maneuver that you can perform: foot overhanging the side of the bed, plantar flexion, inversion. You grab the foot and pull down or pull the foot anteriorly in order to see if there is gapping between the two osseous structures. As we move further back, again using the lateral malleolus as our landmark to palpation when doing ultrasound, you then place your transducer transversely and slightly posterior to the lateral malleolus. At this point, we'll have an image such as this with the fibula and the peroneal tendons underneath our transducers. The peroneus longus is the more superficial of the two. The peroneus brevis is the deeper of the two. They lie within the retromalleolar groove on the posterior aspect of the fibula. As they course distally, you can see here, this is the peroneus brevis, which attaches to the base of the fifth metatarsal, and the peroneus longus, which courses along the undersurface of the foot on its way to the great toe. I'd like your attention to be seen that the peroneus brevis actually is the more superior of the two when you look at them laterally, where the longus is the more inferior of the two. In addition, there is this small hypoechogenesic line here. This happens to be the superior peroneal retinaculum. This holds the peroneal tendons within the retromalleolar groove and prevents them from subluxing. Injuries to this region will result in subluxation or dislocation of the peroneal tendons. It looks somewhat dainty and wispy, but it's actually a quite strong structure. It usually attaches to the posterior lateral lip of the fibula with a small fibrous component. I will show an example of some injuries on subsequent slides. Again, not only seeing the tendons in the short axis, but it's also important to identify them in the long axis. Again, PL corresponding to the peroneus longus, the nice fibular pattern. Here we can see the peroneus brevis deep to the peroneus longus, slightly above the level of the ankle joint. More distally, you can see the peroneus longus attaching to the base of the fifth metatarsal, and the peroneus longus on its course along the undersurface of the foot. We can see a lot of pathology. We do have an ankle surgeon who has patients come in who have had multiple fractures or injuries to the ankle and asks us to evaluate the peroneal tendons, particularly in the post-op state. A lot of them have instrumentation and therefore difficult to evaluate some of these things with magnetic resonance imaging secondary to Bloom artifact. And in this case, ultrasound has a major advantage. Here on the upper image, you can see PL again, peroneus longus, the more superficial, peroneus brevis, the deeper structure. There's enlargement and tendinosis of the peroneus longus, and we can see this linear cleft of hypoechogenicity, 90 degrees to the short axis and parallel to the long axis of the peroneus longus, most in keeping with a longitudinal split tear. Below we can see a typical tear pattern for the peroneus brevis with a longitudinal split tear. Typically you'll see what looks like 3 tendons, 2 tendons similar in size which are deep, which are the peroneal brevis tendons with a split tear and gapping of the 2 portions of the tendon, with the peroneus longus interspersed and falling into the gap. I find this much easier to identify when we look under real-time ultrasound, so I thought I'd show this case. Again, peroneus longus, peroneus brevis, they don't actually look that bad that high up, starting to see some tendinopathy there. And as we course further distally and along the descent, you can see that the peroneus brevis now turns into 2 separate tendons here, with the peroneus longus falling into the gap of that longitudinal split tear. Easy to identify, very common type of tear pattern that we encounter in our everyday practice. Again, able to not only diagnose some of these entities, but also treat. Here's a case of tenosynovitis involving the peroneal tendons. Again, marked distension of the tendon sheath, a lot of debris and thickening, as well as some hyperemia. Easy to place our needles. Again, I come from a transverse plane, place our needle inside, and then administer. Typically, we give a cocktail of anesthetic and corticosteroid. I'm going to talk just a little bit about dislocations and subluxations of the peroneal tendons. And the reason being is that often I have not diagnosed a peroneal injury of the superior peroneal retinaculum on MRI, although the patient clearly feels a snapping sensation, the physician feels something that appears to be snapping, but when we do static imaging on MRI with the patient fixed in a coil, it appears that the tendons are appropriately located and often difficult to identify that superior peroneal retinaculum. So in the normal state, we have the peroneal retinaculum that attaches again to that posterior lateral aspect of the lateral malleolus with a fibrous component. The peroneal tendons will be within that retromalleolar groove. There are different types, and I don't think it's important to know the types, but I think it's important to understand some of the pathology. Here we can see that the peroneal retinaculum looks like it's intact. However, the fibrous portion that attaches to the lateral malleolus has actually been pulled off and there is periosteal stripping. This is the case that is difficult to identify outside of ultrasound. This allows some gapping in this region, and the tendon, either the longest or the brevis, can sublux anteriorly into this gap. I will show an example of this subsequently, and typically in order to give a little bit of tension on the peroneal tendons, what you will do is place the foot in dorsiflexion and eversion, or if you'd like, you can have the patient make a circular motion with their ankle and keep your transducer in the transverse plane right over that groove and see if you can identify any evidence of subluxation. I will say that transducer pressure is important. You do not want to be pushing very hard at this time because you want to allow these tendons to sublux. You could actually hold them in place while doing this maneuver, so you want to really use quite a large amount of gel when doing this. Obviously, a type 2 is going to be more easily identified with all imaging modalities. It's a complete avulsion of that retinaculum with essentially dislocation of the tendons. Typically, the brevis will be the more anterior. It can be easy to get confused as to which tendon is which, but almost always the brevis will be the anterior tendon and the longest the posterior tendon. With type 3, I find radiographs to be helpful. Usually on the radiographs, you'll see this small avulsion fracture off of the lateral malleolus. That's right where that fibrous attachment is. And then typically you get periosteal stripping and again, dislocation of the tendons. And I have yet to find a type 4 in our practice. It's extremely rare. If anyone does have an example, I would love it. It's an intrasubstance tear of the retinaculum with the tendons subluxing through that area of discontinuity and dislocating along the lateral aspect of the lateral malleolus. Again, you're going to place the foot in dorsiflexion and eversion. Keep your transducer over the lateral malleolus and slightly posteriorly. And here you can see the peroneus longus and the peroneus brevis. You can see that here's the retinaculum. We thought that there was some gapping here. We could not identify the normal attachment site, felt that there was some periosteal stripping, but it looks like the tendons are normally located. Here's when these dynamic maneuvers help. You can see all of a sudden the longus just snaps right over the peroneus brevis. Again, here the patient's getting stuck or having trouble actually relocating it at this point, and you'll see it'll finally relocate. And then once it relocates, we unfortunately kept making them do circles, and then they slipped out again and pop back and forth. It was diagnostic for a type 1 injury. They actually did have an MRI before this ultrasound, which was read as negative. Moving along that lateral ankle, we then usually look at a structure called the calcaneal fibular ligament. This structure goes from the undersurface of the lateral malleolus and takes a posterior and inferior oblique course to the calcaneus. It does form a sling for the overlying peroneal tendons. Here we can see the lateral malleolus. You see the fibrillar portion of the calcaneal fibular ligament. Here's the calcaneus, and you can see the peroneal tendons above it. It's almost as a hammock for the peroneal tendons. I will also tell you, if you have trouble finding this, this can be a little bit difficult to identify given its course and location. If you actually look at the peroneal tendons in the short axis, typically they will be in the short axis and you'll accidentally find the calcaneal fibular ligament because as they course over, they're almost always in the short axis. Again, if you have trouble seeing this, in order to make this taut, you can place the foot in dorsiflexion and it will become taut and elevate those peroneal tendons. Here's an example. Here's the neutral state where the calcaneofibular ligament is a little more lax and allows the peroneal tendons to lay right on top of it. As you dorsiflex, it will then become taut and elevate those peroneal tendons. You can see this here on the video. Here, this is a calcaneofibular ligament. Here are going to be the peroneal tendons. As we watch the video, you can see that it lifts them up slightly as you place the foot in dorsiflexion. This is also one of the lateral stabilizers, and if someone has a tear of the anterior talofibular ligament, it is imperative that you evaluate this particular structure, because if you have a concomitant tear of the calcaneofibular ligament in addition to an anterior talofibular ligament injury, you pretty much are extremely lax and unstable. Some of the surgeons will prefer to do a reconstruction in that case. If not, the patient is prone to developing early degeneration because of the laxity. They at least should be in a brace or immobilized in order to attempt to allow those to scar in. Moving a little more posteriorly, we then evaluate the Achilles tendon. Typically, we place the patient prone with the foot over the edge of the bed. That way we can get good imaging of the Achilles tendon. Again, dynamic imaging is going to be key in this particular evaluation. If someone asks you to look and evaluate for a tear, it's important to make the patient perform maneuvers with plantar flexion with resistance. The reason being is you could have a complete tear of the Achilles tendon and still have some plantar flexion because your plantaris can be intact as well as some contribution from your flexor tendons. So you need to put your hand and ask them to actively and forcefully plantar flex. If they cannot, that's fairly diagnostic of a full thickness tear. Full thickness tears can be difficult to diagnose if the two portions of the tendon are directly opposed to each of them. If the patient reports that they're in too much pain to actually do anything and you can't tell if it's a pain thing or if it's actually that they can't plantar flex, you can do a maneuver called the Thompson maneuver. You can grab both sides of the gastrocnemius muscles a little bit higher at the calf with your hand, squeeze them from both sides, and you can actually try this right now. If you cross your legs, squeeze your calf together, and you will plantar flex involuntarily. So you can do that as well if you want to evaluate the Achilles tendon. It's obviously composed of the aponeurosis of the gastrocnemius muscle and soleus muscle, and interestingly, the tendon actually spins, those components spin approximately 9 degrees as they course down to the insertion on the calcaneus. Again, we're going to look for the typical fibular pattern. We're going to look at it in the long axis as well as the short axis. And when we're looking at the insertion on the calcaneus, remember it's somewhat curved, and as discussed in many of the other sections and lectures, you want to change your angle of incidence to parallel this area to get rid of any anisotropy and not overcall areas of tendinopathy or partial thickness tearing. In addition, when looking at this closely, especially if you're using high resolution imaging, there is a fibrocartilaginous portion of the Achilles tendon distally at insertion, which helps integrate it into the calcaneus. It typically appears like a small comma, should not be diagnosed as an intrasubstance tear. Anteriorly, we'll see Kager's fat pad here, and the flexor hallucis longus. Typically, the tendon high up will be more comma-shaped, with the anterior portion being concave and not convex. We should see the nice fibular pattern throughout, however. Here we can see a normal Achilles tendon on the patient's asymptomatic side. Nice fibular pattern as expected. On the asymptomatic side, you can see marked thickening of the tendon, a focus of hypoechogenicity along the anterior aspect. I think it can be difficult to determine area of tendinosis versus areas of partial thickness tearing. Some clues that can help you: if part of the fat from Kager's fat pad insinuates into that area, you know it has to be partially torn because that's how the fat is getting into that area. Or if the patient has fluid and it insinuates into that area, you can tell that it's a partial tear rather than tendinosis. In these areas of hypoechogenicity, if you look on the short axis images and you actually see that fibular pattern coursing through that area, it almost certainly is going to be tendinosis because you're continuing to see those fibers through that region. You can see that there was hypervascularity within the area of tendinosis, and we saw distension of the retrocalcaneal bursa, which is a bursa which lies between the posterior aspect of the calcaneus and the anterior aspect of the Achilles tendon. Now you can see this normally, and the way we differentiate normal from abnormal for a retrocalcaneal bursa is the anterior-posterior dimension. If it's greater than 3 millimeters, then we call it abnormal. Anything less than that is typically within normal limits. See here on case 2, here's an area of thickening also of the Achilles tendon. This is occurring proximal to its insertion site, approximately 2 to 6 centimeters proximal. This is an area called the critical zone. This is the area that is fairly hypovascular and prone to mucoid degeneration, partial tears, full thickness tears, and tendinosis. This is where we see the majority of our pathology given the decreased vascularity to this region. In addition, this patient had distension of another bursa, the retroachilles bursa. Now, this should never be seen on ultrasound. It is not a normal finding. So if we see it, you can call a retroachilles bursitis. This is usually secondary to poor footwear. Here we can see a complete rupture of the Achilles tendon. Here's the MRI with a sagittal view of a water-sensitive MRI. Here we can see the proximal stump, a big gap filled with hemorrhage, and the distal stump of the Achilles tendon. See it quite well with ultrasound. Again, here it is with the proximal stump. Here's the distal stump. Here it's filled with granulation tissue, fat, and probably some hemorrhage into that area of discontinuity. I will show you kind of a finding that I thought was interesting, has been described in the literature. Typically, the distal stump will have a more anterior orientation, sort of flop down. It's been described, and I've seen it multiple times. If these two tendons were opposed to each other and you saw this course without it being a straight course, that almost always is seen in the setting of a full thickness Achilles tear and is a good secondary sign. This one obviously was pretty easy to diagnose given the retraction of these stumps. What do you do in a case like this? Well, here we saw that in that hypovascular critical zone, we saw this area of granulation tissue and inflammatory changes, and thought that there potentially could be a small area that was contiguous, but we're uncertain whether these are two opposing pieces of the tendon or if there was actually a small amount of the tendon intact. And again, this is where dynamic imaging prevails. Here you can see that area stayed intact with both dorsal and plantar flexion. We saw no evidence of gapping. This was in keeping with a with a high-grade partial thickness tear, and the patient was able to resist us with plantar flexion, albeit it was a little bit weaker than the contralateral side. I don't know whether to put this really with the ankle or the foot, but often when asked to evaluate the heel, we are looking at the Achilles tendon and plantar fascia, so I lumped it with the posterior aspect of the ankle. So again, to evaluate the plantar fascia, I find it easier to keep the patient prone with the foot overhanging the bed, place our transducer right on the heel. Here you can see the calcaneus, and here's that fibrillar pattern of this aponeurosis, which extends from the calcaneus all the way to the bases of the metatarsals. This does form a sort of spring for the bottom of the foot. It acts sort of as a shock absorber, and commonly we get injuries to the proximal 2/3 in this area, particularly in runners, with pain that is extremely piercing, particularly when they wake up in the morning and get out of bed and stand for the first time. Here you can see an asymptomatic side. This is the normal plantar fascia. Here you can see thickening of the plantar fascia. We use 5 millimeters. Anything greater than 5 millimeters we call positive. Anything less than 5 millimeters within normal limits from our standpoint. Obviously, the patient is going to be symptomatic as well, and as you push with the transducer, it should elicit the patient's pain. You can give steroids, you can treat them conservatively, you can change their orthotics. More recently, we've been getting patients who have been refractory to all therapies, and so we have been performing platelet-rich plasma treatments to this area. We take the patient's whole blood, spin it down in a centrifuge, and then place our needle in the area of fasciitis and inject a small aliquot of this platelet-rich plasma, usually approximately 3 cc's. We also fenestrate the fascia as well. They will not get immediate pain relief. It usually takes months for them to feel the effects of PRP. This is a patient that originally had 2 years of pain, continued to run, however, unfortunately, and ended up tearing. You can see on this fluid sensor sequence, this bright area here is a tear in the plantar fascia. There is some of the fascia remaining. You can see a lot of high signal here on the undersurface of the fascia with inflammatory changes there, and they even had high signal in the adjacent calcaneus consistent with some bone marrow edema. We performed the PRP 3 months later. This is what their MRI looked like. They're still a little thickened, but you can see that all that edema had subsided and a part of the tear had actually healed in and fibrosed. But more importantly, this patient was completely asymptomatic and they had had pain for 2 years, had undergone steroid therapy, had undergone all the conservative measures. So platelet-rich plasma, it's defined as a platelet concentration higher than the physiologic platelet concentration found in healthy whole blood. So the average normal platelet count is approximately 200,000 per microliter. With PRP, you get a 5-fold increase in concentration, so approximately 1 million platelets per microliter. And we're placing a higher concentration, hopefully at the site of injury, and putting concentrated growth factors in that area. Also, when looking at the plantar fascia, you want to look for other lesions that potentially could be causing pain or impingement. Here again, you can see the plantar fascia in its full extent. We saw this hypoechogenic mass, kind of lobular appearance, avid increased vascularity. It was directly opposed to the plantar fascia. This ended up being a plantar fibroma as expected. The way to differentiate this from something more ominous, such as a synovial cell sarcoma, is that these are always opposed to the plantar fascia. They're almost always multiple, either on the same foot or you can see them on the contralateral foot. This was a single one on this foot. However, when we looked at the patient's other foot, we saw multiple other similar appearing lesions, these hypoechogenic nodular lesions with increased vascularity opposed to the plantar fascia. Typically, these are treated conservatively. It's an easy diagnosis to make on ultrasound. We'll move our attention now to the medial ankle. You can either place the patient in a decubitus position or you can put them in the frog leg lateral. Again, we're going to use bony landmarks to help us out, so we're going to palpate the medial malleolus and place our transducer along the posterior aspect. Here is the tibia and the medial malleolus. Again, we're going to use a mnemonic, Tom, Dick, and Very Nervous Harry. This stands for the tibialis posterior for Tom, the flexor digitorum longus for Dick, and very nervous is for the tibial nerve, which this patient had a split one, the artery, and the posterior tibial vein. And Harry stands for the flexor hallucis longus. Again, we're going to look at these in the short axis as well as the long axis. Here you can see that the tibialis posterior extends along the lateral malleolus, comes down and inserts on the navicular bone. The flexor digitorum is slightly more posterior, courses along the undersurface of the foot, crosses the flexor hallucis longus as it makes its way to the 2nd through 5th digits, and the flexor hallucis longus comes down, goes under the calcaneus, a portion of the calcaneus called the sustentaculum tali, and then courses to the great toe. Again, I think looking in the short axis is the best. Here you can see the tibialis posterior as it extends down to the navicular. Remember, as it makes its way to the navicular, it does split and branch. It actually fans out because there's a portion that goes to the navicular and then smaller branches that go to the cuneiforms as well as the 4th metatarsal. And so you have to make sure that you do not overcall tears at its insertion at the navicular. I'm going to talk a little bit about the flexor hallucis longus and tarsal tunnel. This is a little bit more difficult sometimes to evaluate under ultrasound because it is somewhat of a deeper structure. Here you can see the level just above the ankle joint at the level of the medial malleolus, similar to the images I saw on the prior slide. Here's the flexor hallucis longus, and at this level you can see that it still has a large portion of its muscle belly. Here again is the tibial nerve, which at this point has already branched, which is somewhat atypical, and you can see the posterior tibial artery and the posterior tibial veins. As we make our way slightly more inferiorly, we can see that the flexor hallucis longus courses through a fibro-osseous tunnel along the posterior aspect of the talus. You can identify both a medial and lateral tubercle in this region. It's important to identify the flexor hallucis here, not only to make it easier for you to find this particular structure, but this is where an area of pathology occurs commonly with this particular tendon. Often people can have an overgrowth of their lateral tubercle, or they can have an accessory ossicle here called an os trigonum that can occur usually on top of that lateral tubercle and can cause a little bit of irritation to the flexor hallucis longus. As we go even more inferiorly, you can see the flexor hallucis longus as it courses underneath the sustentaculum talus. This is a portion of the calcaneus, so this is all calcaneus. Here you can see the outpouching of the sustentaculum talus, and the flexor digitorum longus actually courses over the sustentaculum talus. We can see the abductor hallucis muscle, the quadratus plantae muscle, and the tibial nerve. At this point it is branched. It branches into a medial and lateral plantar branch. The medial one will be the superior one, The lateral branch will be the more inferior one. And again, this is with compression, so we're mainly seeing the artery. Without compression, you can see that the veins come into play. This whole area is where the tarsal tunnel is. Here you can see the contents of the tarsal tunnel. You can see the posterior tibial tendon here. Again, here's the flexor digitorum longus. Here, coursing over the sustentaculum. Again, the flexor houses will be here, tibial nerves, and then you can also see the flexor retinaculum, which kind of houses this area of the tarsal tunnel. We often get referred patients who have neuropathies to the tibial nerve. We're looking for masses within this area that could be exerting mass effect on the nerve, or potentially small nerve sheath tumors of the nerve within this region. This is the posterior tibial tendon. I thought I'd show you an accessory navicular bone. This happens to be my foot. I was having a little bit of pain after running and decided to ultrasound my foot. And so I saw this nice example and decided I had to show it in the lecture. So this is the posterior tibial tendon. You can see this rather large ossicle, and then this is the navicular bone. What happens is this ossicle forms a pseudojoint called a synchondrosis with a navicular bone. And over time, you can actually pull on that synchondrosis and get irregularity. Luckily, I had a nice smooth surface, fortunately. And what I usually do is we'll put color Doppler in that area to see if there's any area of inflammation. If it is, then the patient could have what's called accessory navicular syndrome and have inflammation from the posterior tibial tendon pulling on this type 2 accessory bone and causing some micromotion at this synchondrosis. There's also another type, a type 1, where the little bone will be actually within the substance of the tendon, but the tendon will continue on and attach to the navicular. That usually is of no consequence. The only reason I bring it up is that I don't want people to call those avulsion fractures. The tendon itself will look completely normal. Here again, when we're looking at the tarsal tunnel, this was a patient. This is an axial fluid sensitive sequence MRI. This is a coronal and this is a sagittal. This patient had this multilobulated lesion consistent with a ganglion cyst within the tarsal tunnel. Again, here's Tom, Dick, and Harry. So you can see that Harry, which is the flexor house's longest, is getting pushed and displaced slightly by this ganglion cyst. And here you can see some of the vasculature, those are the veins, but also the tibial nerve and artery were being compressed by this lesion. The patient was having symptoms referred to this. The surgeon was wary of actually going in there and removing this. Typically, they will go in and find the neck of these ganglion cysts and remove the entire thing. He was concerned because of the proximity to the nerve as well as to the vasculature, and so he asked if we would try to aspirate this particular ganglion cyst. So under ultrasound, it was clearly evident. We decided to take sort of an Ob-like approach to avoid the neurovascular bundle as well as to avoid the tendons. We placed the needle into it. Unfortunately, initially, even with a 16-gauge needle, I was unable to aspirate the fluid. These can be quite viscous and gelatinous, and therefore I put in a small amount of lidocaine to break up the viscosity and burst it, as well as fenestrated the wall of the ganglion cyst. After we were done, this is what it looked like. I ended up putting just a touch of steroid in there to help with any inflammatory response. The patient's been asymptomatic for the last 3 years, so far it's been successful. Often when going after these ganglion cysts in most parts of the body, really the success rate is fairly low, about 20% of them resolve. So looking now on the medial side of the ankle now, again, we're going to look again at the medial malleolus. So we'll find the medial malleolus and now place our transducer in a coronal plane to evaluate the deltoid ligament. It's named the deltoid ligament because it's somewhat triangular shaped with the apex at the medial malleolus. They're both superficial and deep fibers. Often those are sort of contiguous and can be difficult to determine which ones are the superficial and which one are the deep. There are components that go from the medial malleolus to the navicular, the tibial navicular component, from the medial malleolus to the calcaneus attaching to the sustentaculum talus, the tibial calcaneal, and then the posterior tibial talar. There also is an anterior tibial talar. Here is a coronal MRI, fluid sensitive. Again, here's the medial malleolus. Here is the talus. Here are the deep portions of the deltoid ligament. This is how we're going to place our transducer. And notice that this black area is, again, Tom, Dick, and Harry. This is the posterior tibial tendon. Here again is the medial malleolus. Here's the talus. And here you can see the fibrillar patterns and the deltoid ligament, the tibial talar component. Again, the posterior tibial tendon will be superficial. As with the peroneal tendons and the calcaneal fibular ligament, usually the tendon is in the short axis at this point. So again, if you're evaluating the posterior tibial tendon in the short axis as you come across, often you'll accidentally find the deltoid. So if you're having trouble, just follow the flexor tendons along their course, and often it will come into visualization. You can see all the components. Here is again the medial malleolus, here's the navicular, and here's the portion of the talonavicular portion of the superficial fibers of the deltoid. Here's an example of a tear. At first we were uncertain whether this was a partial thickness tear or a full thickness tear. Again, dynamic imaging with ultrasound is invaluable, and here you're going to place the foot in E version to try to pull those fibers off. Here we were certain that there was some type of tear, but you can see under dynamic ultrasound, you can see that the fibers will pull off right here, and there will be a gap between the medial malleus and the teres. Also, there was gapping of the bones. You could feel that on exam. So could the orthopedic surgeon. It was consistent with a full thickness tear of the tibial talar component of the deltoid ligament. I'm now going to move on to the foot. I'm not going to spend much time on the flexor tendons. You can evaluate the flexor tendons of the foot both in their long axis and short axis. They're very superficial. Similar to any other tendon, you're going to make sure that there are no areas of hypoechogenicity, keeping your probe 90 degrees to the tendon. You also will move the toes with flexion and extension in order to evaluate them. But more importantly, we're typically going to be evaluating the metatarsal phalangeal joints as well as the interspaces. I'll call your attention to this nice triangular hyperechoic structure. This is the plantar plate. It's an area of fibrocartilage. It really helps to stabilize the metatarsal phalangeal joints, and as you can see, it actually forms a cushion over the articular portion of the head of the metatarsal. Here is the head. This low signal on top of it is part of the cartilage, and this covers the cartilage and essentially cushions the cartilage. It also stabilizes this particular joint because it is also in continuation with both the medial and lateral collateral ligaments as well, and often those will be stripped partly with injuries to the plantar plate. We can see the flexor tendon superficially here. It also protects the flexor tendon when people are running and putting weight bearing on their ball of their foot. We evaluate it again with flexion extension. It should stay directly opposed to the proximal phalanx. We should see no evidence of it being pulled off or any hypoechogenic line along the undersurface. Here's a diagram of what it looks like. It does cover from the proximal phalanx and comes around and covers a portion of the head of the metatarsals, that is the articular portion. What does a tear look like? Well, here's our normal that we saw earlier. A tear will have a little area of low hypoechogenic signal along the undersurface of the plantar plate, interspersed between the plantar plate and the proximal phalanx. It was hard to elongate this picture because the patient's toe continued to sublux as we were trying to get good imaging. It was obvious that he had a tear not only of the plantar plate but extending into the collateral ligaments. Well, the interspace is an important area to interrogate of the foot. We get a lot of the podiatrists sending us people who have foot pain that they think might be a bursitis or potentially a Morton's neuroma, which is an area of scar tissue within the digital nerve, typically caused, they think, from patients who have metatarsal heads that are fairly closely opposed, resulting in impingement and fibrosis around the digital nerve. When we image these, if we look at the two metatarsal heads, we place the transducer in a sagittal plane, we push with our fingers on the top of the foot, and on the plantar aspect of the foot, we put our transducer pushing to see if we can splay those metatarsal heads and see within that interspace. On this patient, we found this hypoechogenic structure, and this could be a Morton's neuroma or potentially bursitis, and that's again where I think ultrasound is better than magnetic resonance imaging. With MRI, you typically have to give contrast to help distinguish between the two. With ultrasound, all you have to do is push. So here's us pushing with our finger here. You can see that this structure does not compress. So this is in keeping with the Morton's neuromas. Morton's neuromas will not compress. If this thing is completely collapsible, that would be in keeping with a intermetatarsal bursitis. What happens if you get a little bit of both? Well, you can get a concomitant bursitis in the setting of a Morton's neuroma. So if you are able to compress a portion of it, but a portion of it is non-compressible, that is almost always going to be a Morton's neuroma with a concomitant bursitis, and we typically give the measurement during the compressed state so they know the size of the Morton's neuroma. The other maneuver you can do once you see something that looks like a Morton's neuroma is called a Mulder sign. Here you're going to put your fingers on both sides of the foot and try to squeeze those metatarsal heads together. If someone has a Morton's neuroma between the metatarsal heads, that will then push on the Morton's neuroma and hopefully get the Morton's neuroma to come closer to the transducer and sort of be squeezed out between the metatarsal heads. Here's an example. Here's the third metatarsal and the fourth metatarsal. So you have your transducer, instead of in a sagittal plane as above, you have this sort of coronal to the foot. Here you can see, if you look right here, here's the neuroma being squished out between the metatarsal heads. Unfortunately, the patient's usually screaming at this point, so I don't recommend doing it 30 times as I did in this particular patient because the fellow was so excited to actually have gotten a positive Mulder sign. So once you see it once, I think you can pretty much stop and give the patient a break. We do treat Morton's neuromas. Often the podiatrists do blinded injections of steroid. We are commonly asked to give alcohol injections. The reason being is that alcohol is a sclerosing agent and will kill pretty much everything in its path. So if the alcohol gets into the subcutaneous tissues or underneath the skin, it will cause sloughing off of the skin and necrosis of the soft tissues. So they send any alcohol injection to us. You can see here, we can easily advance our needle right into the Morton's neuroma. I typically do this with the technologist actually visualizing the neuroma, applying pressure so I can see between the intermetatarsals, because the metatarsals are often closely opposed in these patients. It's very difficult to do this by yourself. So if you can have someone pushing on one side with the transducer being pushed on the other side, you can obviously identify the Morton's neuroma and make sure that you're putting your needle right in the center of the Morton's neuroma. Once in the neuroma, we then administer our about 0.5 cc's of a 20% alcohol solution, and we make sure that the solution stays within the neuroma. If you see a little bit coming outside the neuroma, at that point you would stop and bring the patient back if you needed to do another one. Typically it does require 2 or 3 injections, although some people are good with 1. You just don't want the alcohol to come outside, and particularly don't want it to go into the subcutaneous tissues because you don't want the patient to come back with a little small area of necrosis. So in conclusion, this was sort of a quick review of the anatomy about the ankle. I like to compartmentalize it to look at patients who have focal pain in certain areas. It allows us to do a systemic approach to evaluation of the ankle and foot. Showed you a little bit of the common pathology that we encounter on a day-to-day basis, as well as potential treatments. So usually, again, we're going to start anteriorly. Again, the knee is going to be flexed, as you can kind of see here, and then the foot flat, and you just kind of go at the level of the tibial talar joint. You can see here, can you go ahead and move your great toe? So you can see that one right in the center. Go ahead and keep moving it. You can see the one right in the center. That's the extensor hallucis longus. So you know the one, sorry, let me flip this around. You know the one right next to it. Go ahead and keep moving your great toe there. So you know the one right next to it is the extensor. Remember, it's Tom hates Dick or Tom hugs Dick. You can see that, oh, that's great. So we can see the tibialis anterior here. As he moves the toe, go ahead and move your toe. You can see this one moving, extensor hallucis longus and extensor digitorum longus. As we go down, you can see, I got this, sorry, I flipped it on you. You can see the extensor here, digitorum here is going to split into multiple tendons here. It goes into 4 here. The extensor hallucis here is going to go all the way down to the great toe. And you can see that the tibialis anterior right there where the arrow is going to go down to the medial cuneiform right there. And you can see this one is the largest of the 3 if you get lost. Here's the vasculature right here. And then if you move up and down, you can see a small nerve right here. You can see the pulsation of the artery. And if you follow that nerve down, probably putting too much pressure here, you'll see that it comes across to the other side. And if you want, you can use a hockey stick to actually evaluate a little bit better. For the purpose of the time, we'll just do it rather quickly. Again, you can look at the ankle joint. You can see he's got a nice ankle joint. Again, here's the tibia up here. Coursing down, there is the talus. Again, there is that hypoechoic area, which is the cartilage overlying as well. You can see the head, the neck, and then the head as well. So you can see the tibial talar joint. Here's the anterior recess. You can slide a needle right in if you need to. Okay, why don't you lie a little bit on your side. Here I usually put a little towel right under the ankle here. Kind of helps us to get a little better contact. And again, you can see the bony landmark here. We can see his lateral malleolus. If you put, again, your probe right on the lateral malleolus and then angle it a little cranial, you can see the anterior tibial fibular ligament right there, right in the middle of our screen. Right there, the nice fibular pattern. Would you mind just kind of bringing that on down and zooming in on that for me, please? Excellent. Perfect. You can see it right here. It's pretty normal in appearance. Now, if we angle a little bit more inferiorly, you can see the ligament. He actually has probably a little bit of an injury because it's kind of hypoechoic and thickened. But yeah, this is the anterior talofibular ligament here. Can you go ahead and just put your foot down a little bit, like aim down towards the floor, like this way. There you go. So you can see it right here. A little bit of thickening kind of at that distal aspect there, but otherwise okay. And you can actually see that there's a little bit of ossification right here, right at the insertion. Probably had an old injury there as well. So you can see it. Again, I'm not going to do some of the maneuvers because you can do the hands-on session for the purpose of time to look during dynamic ultrasound. I'm happy to do that if you want to come to the hands-on session. Here we're going to look at the calcaneal. Again, this is going to course kind of posteriorly like this. So you're going to put your probe on the lateral malleolus. There you can see the perineal tendons on top, and as we slide back and forth to see it, we can see there's the calcaneal fibular ligament. You want to turn your transducer to get it in its full extent, and here you're going to ask him, go ahead and bring your toes up towards the ears and dorsiflex. So if you dorsiflex, you'll see it a little bit better. So here you can see the calcaneal fibular ligament right here, perineal tendons. Go ahead and relax your foot, keep relaxing it, and then bring your toes back up. Really hard, bring them way up. So you can see that in its long axis as well. So you can see it, but again, you can see that those perineal tendons in their short axis, if you follow them, you'll easily find the calcaneal fibular ligament. All right, why don't you lay on your belly real quick. Again, fairly easy to identify the Achilles tendon. Here again in the short axis. See the Achilles tendon right here, fairly easy to see. You can follow it all the way up, right in here, fairly nice. You can go on your long axis as well. Again, when you're looking in this area right at the insertion of the calcaneus, you want to heel it in to make sure that you don't have any anisotrophy in that area, but we can see it in its long axis, nice fibular pattern. Again, this is going to be where the retrocalcaneal bursa is. You can also see Kager's fat pad right in here. Nice fibular pattern, long axis. But again, remember in this area right at the insertion to make sure that there are no areas of hypoechogenicity and just kind of heel it in, so just straighten it out. If not, you can see that you'll start getting anisotropy there. So you want to heel it in to make sure that you can see it. You can have them go ahead and kind of flex your foot. You can have them move the foot. Go ahead and do it again. Just go ahead and do that real slow so you can see the motion of it. Again, keep doing that. Good. And then here you can see the soleus muscle right there. And then this is going to be the flexor hallucis at this point as well. You can see a nice fibular pattern of the Achilles. All right, why don't you lay back on your stomach. So again, here's our medial malleolus. I'm going to just try to relax this foot a little bit here. So once you find the medial malleolus, you just put your probe posterior to it. And you can see posterior to it, there's, again, Tom, Dick, and Harry. So that's the posterior tibialis right there. Dick is right next to it. You can actually see them separate here. So here's Tom, here's Dick, and so you can follow those down. And then Harry is going to be way over here. And you can see the artery, you can see the nerve right next to the artery right here. Would you mind magging up on that a little bit for me? Good. So you can see the artery right there. So Tom, Dick, and very nervous Harry. Here's Harry over here, and as we come down, you'll see that Harry's going to go into that groove that we talked about. Right here, this is the back of the talus right here, with the medial and lateral tubercles that we discussed. There's the flexor hallucis longus. Again, the nerve is going to be pretty close to it. There you can see the tibial nerve as well. If you push really hard, sometimes people will actually get a little bit of numbness or tingling in their foot, so be careful. But the nice vesicular pattern of the nerve. The nerve will then split. You'll see there, it's starting to split as you start going down into the tarsal tunnel. And then if you want to look again, here's the sustentaculum. So here's the calcaneus, here's that portion of the calcaneus, that's the sustentaculum. And you can see here, here's the flexor hallucis longus here, tibial nerve on top of that. Here's the flexor digitorum coming over that area, and then you're going to see some of the posterior tibial tendon right there. So if you can identify that nice portion of the calcaneus, you can actually see the structures quite well. And then for your deltoid, again, what you're going to do is you're going to position your transducer right over the tibia. I'm going to kind of try to get a little better contact here by putting a towel underneath. Keep your foot up. Yeah, there you go. And once you get onto that area there, you will see the area of the deltoid ligament. Looks like his might be a little incompetent. We'll look at some other part of it. See if I can get a little better contact there. Trying to see the more anterior fiber, see if I can show you the superficial portion of it, but his is a little bit indistinct, unfortunately. Here, let me get a little more goop. Oh, I'm sorry. So here you can see, would you mind freezing that for a second? Right there. You can see some of the fibers right in here with the posterior tibial tendon. His was a little irregular. I'd seen it earlier. I think he had an old injury to his deltoid ligament. But again, you'll see that the tendons in the short axis, if you follow them, so if you're coming on the posterior tibial and you come and follow in the short axis here, coming down to that navicular, you can see that where the deltoid ligament would reside. It's going to be right in that area. You can see some of the fibers deep right there. Again, can you freeze that for me? You can see some of the fibers here somewhat deep, but his was a little bit amorphous, so I knew that he had injured it at some point. Thank you. Again, there's a little portion of it right there.